I hope my screen is visible to all. Am I audible?
You are audible, Dr. Zubair.
All right. So another 2 minutes. Yeah, then we can start on time. So good evening, everybody. Welcome you all to the Diagnopool webinar. A little bit about Diagnopool since we have time. This is a forum just started to share knowledge, and definitely it's free of cost because we all as lab professionals want to enhance our knowledge. That's the whole idea of having this forum. And we plan to now have quarterly programs every 3 months. That would be better to avoid webinar fatigue as well. However, if there are, it's an open forum. If anyone is interested to have present more frequently, they can directly approach me as well, and we can schedule some intermittent program. The idea is number one to give chance to everyone to present. That is the idea, that everyone has talent and capacity as well, but maybe we don't get forums to present. That's the reason of having this forum here. So it's my honor and privilege to welcome today's guest speaker, Dr. Supriya, whom I have known from my previous association at Oxford Medical College. And from then on, she has done a lot of good work working in the leading diagnostic labs in Bangalore, right from Apollo Diagnostic. And then now she has worked in Aster Labs, right? And she has made her niche for herself. And now currently she's working as associate professor in Department of Biochemistry at PES University Medical College Institute at Bangalore. It's a new college from the prestigious PES group, right? And she has tremendous amount of experience in this field, practically as well. And so Dr. Supriya, she has done MBBS and MD in Biochemistry from Rajiv Gandhi University of Health Sciences with a total experience of more than 10 years. She's associate professor, as I mentioned, and lead consultant formerly at Aster Reference Lab. She has also done her General Management Healthcare Executive Program from the prestigious IIM Bangalore and postgraduate diploma in Family Medicine from CMC Vellore, having more than 10 national and international publications, has received the Corona Warrior Award by IMA Bihar, Aster Pride Award. Her fields of interest are in newborn screening, metal marker screening, diabetes, depression, and anxiety disorders. So I will stop sharing my screen now. And yeah. And over to Dr. Supriya. And also here, I will request my colleague, Dr. Krishna, to take over the proceeding as I have an urgent meeting to attend. I will come back shortly. But Dr. Supriya, please do share your screen now and we can start the meeting.
Thank you, Dr. Zubair, for such a nice introduction.
Most welcome, ma'am. Yeah.
So today topic is one of my favorite topic, and I want all of you to be little bit aware about those who are aware of this, no problem. Those who are not aware of, I will talk today on this topic. You all can go through it. Let me share my screen first. My screen is visible to all of you?
Yeah, it's visible.
Okay, thank you so much. So today topic is newborn screening, and in short we tell is it's an NBS. So newborn screening is basically a public health awareness. It is just a screening to all newborn who all are born on this earth. We should screen for this few diseases, which I will tell you in subsequent slides. So this is a screening test. So as soon as we will tell any newborn parents that we want to take few drops of blood from your newborn to do some newborn screening, they will become panic. What happened? Why my kid is not well, or is there any disease or anything? So nothing to do like that. We have to educate the parents that this is just a screening test. Your baby is absolutely fine. We want to take only few drop of blood. How that nowadays in all hospitals they will do heel prick and take for that glucose level to know whether baby is hypoglycemic or not. So to test that, like that only, we will also take a few drops of blood, hardly 1 or 2 drops of blood, and we will tell you about your newborn, whether they are having any deficiency or they are not. Almost of 99.99% it is normal only, but we need a few drops like that. We have to convince them. And if there is what is the consequences if we will not do this, and in by any chance 0.001% also if your baby is having any problem, what is the consequences we have to tell them. Because by seeing we cannot know that baby is having any problem. So let us do this test, go ahead. So we need to convince the parents, because parents are not educated. Our normal public does not know about newborn screening at all. So we as a medical professional needs to educate the parents as well as the doctors also. Our clinicians also, they are little bit hesitated to order this test. Neonatologist, we need to convince the gynecologist, obstetrician, that any baby born, please go ahead with this test. This is just a screening test. We need to convince. That is the main important thing, that agenda today I am going to talk about. So my objective of today's session is to understand the importance of a screening test, or to define the what is inborn errors of metabolism. Okay. So newborn screening is basically about inborn error of metabolism, to find out what is their biochemical aspects, and to know what is the laboratory protocol and various aspects of newborn screening. So my today's talk or totally focus on what is the laboratory protocol. Once we will take the sample, what we will do, how to take the sample, and all those things. Where all we are facing problem in the laboratory during doing this newborn screening. Basically, screening is a process to identify apparently healthy people, or here the people is the newborn, who may be at increased risk of a disease or a condition. But now apparently you will see, by seeing you can't find out the person is having any problem or the baby is having any problem. So this is a screening test, not a diagnostic test. There is a difference between screening and diagnostic test. So newborn screening is just a screen, as I told you. Screening results by themselves cannot determine the presence or absence of a disorder. By chance, if I tell something is positive also, it doesn't mean that the baby is having that. So for that, we need to go for a diagnostic results, which refers to a combination of, we have to correlate with signs, symptoms, or any further blood test or urine test or any other results. So we have to see various things to diagnose that, to confirm that that thing is there for your baby or not. So this is just a screening test. If the screening comes positive, then only we will go for a diagnostic test. And after that, only diagnosis is confirmed by the your pediatrician or neonatologist. Let's coming to what is newborn screening or inborn error of metabolism. So inborn error of metabolism from a large group of, this is a large group of genetic disease involving defect either by the gene coding defect is there for enzymes or any receptors or any cofactors in the metabolic pathway. So what will happen if any enzyme is absent or it is not the proper? We all know that enzymes are very specific to from substrate to product forming in our body also, either carbohydrate or protein or fat metabolism. So if any enzyme genetic code defect is there, that enzyme will become something else. So the form will be different in the body. So the metabolic pathway will not be completed. So the baby will not get the energy or that product what is required for the body, and the abnormal product will be accumulated behind. So that will harm our body in the toxic level. So this is the whole concept of finding out inborn error of metabolism. So it is present in the all means it is present in the newborn period or in the infancy, but that time we cannot diagnose. Some disease we can diagnose immediately also. I will tell you later. such as fatty acid oxidation defects or milder variants of classic metabolic disorders. It may not be detected until adulthood. The baby will become adult. After that only we will get to know there is some defect. So despite of long asymptomatic period, their consequences can still be devastating, like mental retardation or some developmental defect or something that may lead to sometime death also. So better to get all newborn screened for this newborn screening. So it is basically a set of blood tests to look for evidence of certain endocrine and genetic disorders. Early detection and prompt treatment can make a difference between a huge difference basically. That baby can become healthy development as a normal baby also, and a lifelong impairment or possibility of death can be prevented by early detection and prompt treatment. So this is the motto of our newborn screening. And I feel every child is so better to start all. We have to request our government to or the clinician to understand the severity of this or the need of the hour and start newborn screening in all hospitals wherever babies are born. This slide is showing who is the father of newborn screening, basically Robert Guthrie, who has discovered first time, and he is known as father of newborn screening. So as I told you, this newborn screening is a public health activity that is performed on all newborns. Testing is done by holistic shortly after birth for early identification of those babies affected by certain genetic, metabolic, hormonal, or functional condition for which there is effective treatment is available with early intervention. So according to WHO, 140 million children are born every year, of which 5 million children die in the first month of life in the developing countries, and in 4 million children are born with some genetic abnormality. So you can understand that out of 140, there are 9 millions, out of which 5 will die and 4 will be having some genetic abnormality. So we can prevent this by doing this newborn screening. So this diagnosis can be preempted, the complications can be controlled by doing newborn screening. So many lab offers NBS nowadays, and every newborn, the best chance for long life and healthy life, we should think, and we should start newborn screening wherever we are having our setup. It can be started in a very small setup to a very large setup also. I'll tell you later in this presentation. So in this slide is showing how inborn error of metabolism, what it is. It is a biochemical disorder which can lead to mental retardation or permanent disability if not treated or left untreated or undiagnosed. It can also go lead to death of the baby. So this is as per me, this is most crucial test. We also take initiative. We should intervene for this preventable cause of child mortality. So we basically do the hemoglobin disorders. We will find out what all hemoglobin disorders baby can have, or either this is a metabolic errors, like I told you, like metabolic pathway, some enzyme deficiency or coenzyme deficiency, or it can be hormonal imbalances also. Hormones also can be shortage, or it can be more in the body. So these all we'll find out through newborn screening. So most common inborn error of metabolism are congenital hypothyroidism, like from birth only baby will be having high TSH. That is known as congenital hypothyroidism, then cystic fibrosis, hemoglobin disorders like sickle cell anemia, G6PD, glucose 6-phosphate dehydrogenase deficiency, or congenital adrenal hyperplasia. And these are basically normal tests, which is the basic test under newborn screening. Apart from this, clinician also do hearing loss, hearing test for all newborn baby. So this is the common and basic test which we need to do for all newborn. Apart from this, also we have extended parameters for newborn screening. There are many tests can be done, but these are the basic tests, most common. So question will come in the mind, when to do newborn. As per our educational MBBS education, we will tell newborn till 1 year of age, we'll tell newborn, then infant, then when we should do for that. When as soon as baby born in the OT or in the delivery bar, no, we should do this after 24 hours of the age. That is the ideal time, and before discharge of the hospital. That I can tell you. In healthy baby, we should take the blood spot after 24 hours of the birth. And if any baby is sick, or like imagine premature baby or baby is in the NICU or something, in that case we can wait till 14 days of age also. Or if baby is getting discharged, before that, immediately prior to discharge, we can take the dried blood spot sample by heel prick. Okay, so and also we have to take care of that there should not be any blood transfusion or anything. And okay, so for the healthy baby, we will take till after 24 hours till before discharge of the baby. For sick baby, we can wait till 14 days, or we can tell the neonatologist non-transfuse. Before transfusion, you can give, and before discharge, we have to take the dried blood spot sample. So this I am showing you a TRF, test requisition form. How we have this is a test requisition form with the filter paper, Wattman filter paper 903 is the filter paper number. In this side only we have attached the filter paper. You can see that there is five round circles in the initially, that is the filter paper part. After that, the page is there in which we have written the newborn basic screening is required or extended screening is required, any other test you require for this newborn, then detail of the baby's mother name, father name, baby name if it is there, or baby of some other name, right? Then the date and time of the birth. Apart from that, we require birth weight, and then male or female. These data has to be filled by the patient, means baby parents or the nurses who are there. They can help in filling this form before collecting the sample. So this might newborn screening kit we will give for that sample collection. In that kit or itself, this form with attached Wattman filter paper spot, the spot circles also will be there. Fiber spot circle we prepare. So we have made customize this. We can customize as per our laboratory, however it is required. So we will have this form with the filter paper. Apart from that, we will have some heel bar moist cloth also we will give with that. Then alcohol pads will be there, or cotton balls can be there. Then gloves for the person who is collecting the sample. Then heel lancet. Then sterile gauge is required. And finally, after taking the sample, we will after care supplies like adhesive tape or something we will put there. So this is the kit, newborn screening kit, sample collection kit. This slide is telling about. And this is very important that all that data should be formed, filled by the parents or the nurse, staff nurse, or the person who has gone for collection. Before collecting, fill all the formalities, and then go for the pricking, because once we'll start pricking the baby will start crying, and all parents and all will become disturbed. So as we collect our normal serum sample like that, first we will fill the TRF form, then collect the sample. Same like that, we will first fill the TRF form here, test requisition form, and any lab ID or that ID sample identification number should be there. Then we will start the sample collection. So sample collection is very easy, only few drops. It is stress free. Heel prick is done for less than 1 year old baby. Yes, sometimes baby will miss. Later on, we will convince the parents that you can do the newborn screening. So we'll take up to 1 year also, and after 1 year also till 3 years. Sometimes we repeat for some babies which will come positive in the initial phase. Later on, we need to repeat. So till 1 year we can do heel prick. After 1 year, we'll do finger prick. You can see here there is a hill showing safe area, that we safe, and that corner one is that green color is the puncture in the safe area. So green color one is the safe area to do the heel puncture. This picture you can see that step one is position of the infant. If baby is in the NICU, very small baby, or baby even in the bed, We have to make the position for the infant. So head should be little upright, legs should be down. So we need heart to increase so that blood flow should be more. Second step, you can see identification of first we will ask what is the newborn name, and before collection we will fill that form and all those things. So those work we will do in the step 2. Step 3, after filling all those things, we should wear the gloves. Next, fourth step is we'll clean that hill, that area where we are going to prick by the lancet. So we will clean it, make it dry. There should not be any alcohol or any other cleaning agent present there, or any oil or any cream. It should not be there because it may give false positive report. So we should clean it nicely, and we should let it be little bit dry. After that, fifth step is there where we can do pricking. After that, we can start collecting sample one by one in all 5 spots slowly. We have to fill each circle, and we cannot take again and again like 2 drop in the same circle. Okay, it has not come properly. So once for all, when we are touching the hill, we should keep on sticking that filter paper till that circle should be round red color. Okay. So once one circle is round, okay, next go to next circle, then third circle, then fourth circle, like that we should move. We should not give two times touching the hill on the same circle. So those sample collection is very important. Otherwise, again, it will give wrong report. Then we need to dry this. So use a drying rack if there are many babies. Some hospital are only for delivery purpose and newborn baby. So there will be many babies born in the same day. So we need to collect many samples, right? In that case, we use drying rack and let the blood spot dry for a minimum of 3 hours. Normal, we should not put it on the in front of blower, heater, or in the sunlight or in the thing. We need to dry this in the normal room temperature, room ambient temperature, normal. So we will let this blood spot dry for a minimum of 3 hours. After that, taking care of the infant, put the collection kit on dry, clean, flat, non-absorbent surface. After drying the sample, send the sample in the envelope and send it within to the lab for the processing within 24 hours of the drying or collecting the samples. What are the problems I am here in the lab and for the sample collection? Somebody mic is I think so open. Please mute it. All questions I will take at the end of the session. So we can see that sometimes the quantity is not sufficient. You can see the first one, circles are not completely filled. The blood did not soak through. Second number, you can see bet is specimen. Specimen is not right for a minimum of 3 to 4 hours. Before that only, they have put it in the envelope and send it to us. In that case also, we can reject the sample. These are the rejection criteria for sample. First one is quantity not sufficient. Second one is it is not right and kept in the envelope and sent to the lab. Third one is super saturated. That I tell you in the same more blood 2 times, 3 times, they will take to the same spot. That is known as super saturated. Or sometimes they will take through capillary tube or something, that is also makes super saturated. Another one is contaminated. The fourth one, puncture site can be squeezed or milked or extra cream or oil, something has gone, so it has gone contaminated. The fourth one you can see is the alcohol is not wiped off during puncture site. As I told you, after wiping off, we should make it dry. So these all are improperly collected samples. So these are the rejection criteria for us. We can ask repeat sample if we are seeing like this type of samples, because this will give, it is of no use of processing also. This will give falsely positive or falsely negative report. So these are the rejection criteria in this newborn screening case. While sample collection, what to do, what or not to do. So we should not dab or color in the filter paper circle before, like by ink, by writing by mistake it has gone to filter paper writing. That should not happen. We should not apply multiple drops of blood per circle. We should not scratch the filter paper. We should not contaminate a specimen. So as I told you, we will send in a envelope so that it should not be touched by the hand. So as per my lab protocol, we have TRF. with the filter paper attached. So everything will be packed in an envelope, neat and clean, new envelope, and then we are sending it, like we are giving it in a bulk to the hospitals. They are using as per their requirement. So it will be closed, sealed pack. So they will open and then they will. So it should not be contaminated. Again, that sample should not be wet. It has to be dried under room temperature. It should not be dried under sunlight or under air vent or any other like we can make in front of heater or blower or something. It should not be like that. So these are the things we should take care of during sample collection. So next, after collecting sample, drying, then putting in the envelope, and then sending it. As I told you, 24-hour is the ideal time, but we will accept till 48 hours because we have to give broad service nearby cities or nearby labs and all to collect there, come to my lab. So we are accepting till 48 hours also. The ideal timing is 24 to 48. This is one scenario you all can see. Just for all serious talk, I thought I'm sharing you. This is one scenario from my 10,000 sample in my lab last year. We have reported 312 positive cases. So this is the scenario. If 10,000 babies can be screened, 312 positive cases we are finding out, and out of which TSH is 13 positive. TSH will be mainly, we will get high TSH. Then 17 hydroxyprogesterone, 29 positive we got. Total galactosemia, that 7 cases was there. G6 PD deficiency is very much prevalent in India. 129 samples we have got out of 10,000. 129 babies were positive for G6PD. Same like that, sickle cell anemia or other hemoglobinopathy, we got 120. So mainly G6PD, TSH, 17 hydroxyprogesterone, and hemoglobinopathy are the more prevalent in India. India basically in Bangalore. I am talking about Bangalore. After I received the sample, okay, dried blood spot has come to my lab. Our lab has received, and we will, while receiving, we will see everything is fine. We have accepted. Okay, we have not rejected the sample. If rejection means, we can ask repeat sample. The baby is there in the hospital, or we can ask them to come and give the sample. So basically I keep on training the nurses every month so that they should not forget how to collect the sample. So it's because unnecessary that newborn how to prick many times and all those things. It is still once in a while we reject the samples and we ask for repeat sample due to sometimes due to improper TRF filling, sometimes improper collection. Most of the time is that improper blood spot where we have to do the test. So once we receive the dried blood spot, we will use punching, hand punching. As of now, I'm using, because there are automatic puncher also is there. I'll show you in the next slide. So this you can see that you have seen in the before pages and all. We have that stapler type of thing where we punch the. So this is a fixed 3 mm hand puncture. We punch the dried blood spot by using puncture, which is fixed 3 mm. Okay. So we will take 3 mm of filter paper with the blood sample and we will put in the veil and we will process the sample. See, you can see this is DBS puncture automated. Here manual is not required, it's automatic. We will put the sample and it will punch automatically 3.2 mm, 4.7 mm, 6 mm. There are different type of diameter of that automated puncture. So at a time we can load 2 plates and then it will punch and automatically sometimes it will read barcode and it will put in the processing veil. Once the dried blood sample is received, we will arrange the plates. We have plates to process this. Not like for serum and all, we have to. For this newborn screening, we will have plates, microveils. So we will arrange the plates as per the panel requested. We punch the dried blood spot by using puncture. As of now, I'm using hand puncture, not automated puncture, which is 3 mm. We will screen all. We will see what all is asked. As we our lab is screen all 57 disorders as per as by LCMS. Then amino acid profile also we do, a cell carnitine profile, biochemical assay, and hemoglobinopathies. If any sample comes abnormal value, we'll repeat the assay for confirmation and immediately we'll inform to the pediatrician or the neonatologist for any abnormal or critical value. After reporting, the specimen should be stored. We are storing at 2 to 8 degrees C up to 1 year. We have started this newborn screening 3 years back, and we have still ideally we should store up to 1 year. But from last 3 years, I am storing all the samples. We can aram store in the fridge, bundle by bundle, daily basis or weekly basis or monthly basis. We can put the anyway it's the envelope only. In the whatever is required, 1 or 2 months we will take, remaining all we will store, and we can store at 2 to 8 degrees C up to 1 year. Nothing will happen to the dried blood spot. It's a very nice specimen. The use of dried blood for biochemical and genetic testing has expanded as filter paper technology has been adopted for the latest analytical method. I'll go through. Next slide. After punching, that we will take in the sample vial. After punching, we will put the reagents and we will put for shaker. Shaker means it will mix. So this is the picture of plate shaker and then incubator. We will incubate, then we will extract the liquid sample and then we will do the testing. So this is the picture of a plate shaker and incubator. This instrument is known as Biotech FLX 800 microplate reader. On the microplate, after putting the sample, this is a fluorescent enzymatic reader to read all amino acid tests we can do on this, like TSH, 70 hydroxyprogesterone, IRT, and enzymatic acid like total galacto, biotinase, G6PD, and phenylalanine. These are basic parameters which we can do in this fluorescent enzymatic reader method. Variant. Then for hemoglobinopathy, we a variant NBS newborn screening by HPLC, high performance liquid chromatography method. So this is a Biorad instrument. We have Perkin-Elmer's also in this, which is very good, and gold standard techniques. And as of now, I'm doing on Biorad variant. We can find out hemoglobins like hemoglobin variant F, A, S, D, E, or C, and then we can evaluate and give the report. So in this hemoglobinopathy, main thing we have to know that any transfusion is done or not. Before giving the sample, there should not be any transfusion. Otherwise, this will give false positive or false negative report. Then we have liquid chromatography, tandem mass spectrometry. We have Waters. There are other company also, LCMS instrument is there like Perkin-Elmer, then ABSI6, then Thermoscientific. These are the main 4 companies. We provide LCMS, liquid chromatography, tandem mass spectrometry instrument, which is very good instrument, and we can find out the amount like quantitative determination of all acyl carnitine or amino acid profiles. Amino acid, how much is that? So this instrument we are using for extended parameter. Basic, as I told you in the previous slide, we have this one for basic newborn screening. Then if this is for hemoglobinopathy and this is for extended parameter. So we have made a different panel. Any lab can make like basic, if as per requirement, like if the patient is not able to pay the money, like extended will be costlier than around 1,500 to 2,000, or depending upon that lab to lab also price will differ, but on an average I am talking about. Then basic like G6PD, TSH, phenylketonuria, cystic fibrosis, 17 hydroxy progesterone, galactosemia, but this we can do in between 500 to 700. Then 3 parameter also, if by chance if somebody, some patient or some government place where they are not able to pay the money only, then in that case we can go for 3 parameters also. So we can customize our test panel and requirement depending upon the person to person, patient to patient, hospital to hospital, lab to lab. It is all in our hand how to go about this. Individual test also can be done. One like phenylalanine screening you do and give IMD panel, I am suspecting, can you do? See, so individual test also we are taking. Hemoglobin HPLC can you do for the dried blood sample? So individually also one single test also we can we can take as a basic newborn screening, we can take as extended newborn screening, we can make our own panel depending upon the requirement. So this you can see that I am showing this what is the we as per my requirement I have made test code, test name, test component, then what is the method. If it is extended or any amino acid quantitative, we need LCMS. Otherwise, I do on flowmetric enzyme assay method. A sample for everything is dried blood spot. At that, on an average, I have written 4 days. Generally, we will give in 2 to 3 days because one day we will accumulate the sample so that that micro plate or microvial is fixed. So if we will do only three sample or 4 sample, it will not work out so much. So we will accumulate little sample and we will process every alternate day. So we do for in our lab, we do for hemoglobinopathies, biochemical panels, amino acid disorders, urea cycle disorders, fatty acid oxidation disorders, organic acid disorders. We'll find out all those things in our lab for any newborn. So these are some, I will not go on detail. These are some disorders detected in the newborn. Like congenital adrenal hyperplasia, biotinase deficiency, phenylketonuria. Most of you have heard all those things, right? CH, congenital hypothyroidism, galactosemia, sickle cell anemia, homocystinuria, maple syrup urine disease, G6PD deficiency, cystic fibrosis. So these are the mainly disorders which is detected in the newborn. Now, coming to the challenges, what all challenges I am facing in doing newborn screening? What are the pre-analytical challenge, analytical challenge, and post-analytical challenge? So this slide is showing about my pre-analytical challenge. I mainly in during pre-analytical improper dried blood spot sample collection, unidentified patients, not collected in hatched area, not cleaned the puncture site with alcohol pads, not by first drop by using gas pad and all. So these are the pre-analytical. Then incomplete baby detail. This also comes like date of birth, gestational weight, type of feeding, type of any transfusion, any other clinical finding. These all are incomplete. That is also a thing facing. We have challenges where we have to again communicate with the team there, where sample has come. So these are the things we are facing in pre-analytical, due to which there is delay in reporting, not dried completely after collecting, sending, improper packing. The card is packed on airtight, not added silica gel or something. Transportation delay also sometimes. After sending many, like after 1 week, I'm getting so not transported or missed the sample. So all those things are the pre-analytical challenge I am facing in newborn screening section. Analytical, during analytical, what we face? We face like sometimes instrument is not working properly because trained and qualified staff is not there, so instrument breakdown ho gaya. Sometimes some shortage of kits, so sometimes, or uh, sometimes we can know that that staff is on leave. Okay, sometimes that lab environment or working place is busy or something. These can be during examination. Generally, I have not faced all those things. We will have proper stock and all those things because we know that this is having a long expiry and there is nothing to worry about. So generally, we will not face the analytical problem. Mainly in pre-analytical and post-analytical only will come. But these are the things which can come in analytical phase. What are these are the challenges? Now coming to post-analytical. Now coming to post-analytical, incomplete clinical history. Imagine I have got a positive borderline case. In that case, I need clinical history, how baby is doing, so that I can think, okay, this is borderline just by point think whether I should take in the positive or we should take in the negative or incomplete report, improper storage of a specimen after examination, invalid clinician contact. So these are post examination challenges I am facing. So we need proper history, we need proper clinician phone number so that we can contact. This is very, very important in NBS. It is very, very important that we, before giving any positive report, we should inform to the clinician. This is the best practice we should avoid so that clinicians should not suddenly, no, no, my baby is doing fine, you are giving me positive, and we can tell, okay, maybe pre-analytical some problem would have been there. That's why, madam, please give repeat sample. Or if baby is not doing fine, we are giving normal report. They will no, my baby is not doing fine. Why? What report you have given, Dr. Supriya? It should not come out. So for that case, clinician contact number is very important. So that number is the post-examination problem. Sometimes they will not give clinician contact number. They will not give patient baby history, or there will be sometimes the technicians will give incomplete reports, like 5 per meter they will do, one bill they will miss to run. So these are the post-examination challenges. So when test values are abnormal in first run, what we do, we will repeat the testing. If anything has come abnormal, we are going to repeat the testing for reconfirmation and correlate with inter-laboratory comparison on certain criteria. Few things are there where I cannot take decision. I am a little bit confused whether to give positive or negative this side or that side. So in that case, I will send ILC, inter-laboratory comparison, to confirm what can be done. So it will be double checked. First of all, we do in our lab 2 times, then we will send for ILC. That is why I have put TAT for 4 days, because if I'll give TAT 1 day or 2 day, I can do it in 1 day only. But I put 4 days so that if values come positive, we can take it into next step tomorrow again, a day after tomorrow again for ILC, then fully satisfied and then give the report. Previously giving report is always good than delaying whatever we have told to the patients. So report is kept on hold, and we will inform the concerned hospital or client about report delay through the mail communication or through WhatsApp nowadays. And after repeat testing, if the result remains abnormal, we'll contact the site, that hospital site staff, to send the clinical history. We'll discuss with the neonatologist for additional information, whether it is baby is having a recent transfusion or what type of transfusion, or baby is on parenteral nutrition, or what is the condition of the baby. So any abnormal report, this is my protocol. So once the abnormal result is approved, imagine I have approved the report, immediately intimate the critical value to the neonatologist or concerned clinician for the further process. They will go for further process. This is anyway a screening test. They will go for the confirmatory test. They will send the serum. If on the dried blood spot they are getting TSH high, then they will send the serums TSH. Then they will correlate. So whatever is the confirmatory test, they will go next test. So better we should inform immediately that we are having abnormal report for this baby. Go, so they will take a call. So critical alert values are informed to the doctors, hospital staff by sending text message or call along with mail communications. So for NICU, a special case consideration we will take factors that can interfere with the screening result, like infant, premature infant are there, like 20 weeks, 24 weeks, and non-born. So they may give false negative or positive value. Low birth weight infants, for basically TSH and 17 hydroxy progesterone results are affected due to prematurity and low birth weight. That is why in my TRF there is a column of weight of the baby. How many weeks delivery, that delay, mother gestational delivery, at what week delivery has happened, 38 week, 40 week, 36 week, 24 week, and what is the birth weight, what is the gender of the baby. So all those columns, TRF, in the TRF it is there. Same like that, if baby is hypoxic, cytomegalovirus infection, septicemia, or trisomies, or biliary atresia may affect IRT levels result. Same liver immaturity may affect amino acid results. Same like that, carrier status may affect all NBS result if any baby is carrier. So what is if baby is having on any treatment like total parental nutrition or SNAP or carnitine treatment, these all may affect my amino acid results, fatty acid results, or organic acid results. So any transfusion also affect the newborn screening, that hemoglobinopathy results. So for these we will see in the NICU baby. Same like that in maternal. If mother has taken previously any therapy, radioactive therapy for thyroid or something, will affect baby TSH also. Same like that, if mother has taken steroid during gestational period, and it will affect the infant 17 hydroxyphosphorus. So all the history we need to take before releasing result. Same like that, next we will face that collection issue, which is everywhere. Transit time delay, unsatisfactory specimen, all those things. One is like multiple elevations. See, generally in normal 99.99%, I will have one or maximum two parameter up. In case of positive, I am talking about, not about normal. But in case of multiple elevations of phenolite, these results are often due to additives to feeding, such as the baby will be on nasal tube, rice tube. A total parental nutrition would have been going on some special protein, carnitines or MCT oil, all those things they will be going on in that. Because of that, we will get multiple elevation of analytes. So we always need to consider NICU babies. Babies on NICU, we have to ask, are any transfusion given? All newborn screening results, especially that hemoglobin, globinopathic sickle cell anemia or galactosemia or biotinase, these all will be affected. So we need to take 7 days post transfusion, one sample. We cannot take during transfusion or on the day of transfusion. So either we should take before transfusion or after 7 days post transfusion, we should collect the sample, or again after that, we need to repeat after 3 months, 3 to 4 months, between 90 to 120 days post transfusion, we need to repeat the test. So as for all blood tests in the laboratory, we will have internal quality control, external quality control. Same like that for newborn screening also, we will have newborn screening quality assurance program. It is managed by CDC, Center of Disease Control and Prevention. They will send us same, we will have dried blood spot type some sample to run, that is aqueous material. We will run, we will send the sample, result will be internal. They will receive it, as my lab is 100% accurate, our accuracy is 100% as of now. And so we do same like that daily QC, as well as before running the test we will run the QC and aqueous, which is given by CDC. So summary of this till now is NBS purpose is to detect treatable disorders before any damage, irreparable damage can occur. So before itself we should find out and we should treat it if it is treatable. Tandem mass spectrometry is the gold standard. As I told you, availability of mass to mass testing led to more standardization of NBS program. In inborn error of metabolism, very non-specific clinical and laboratory finding. This will help. This newborn screening is going to help us. It is diagnostic strategy. Look for abnormal metabolites and normal metabolites in high concentration, and we can find out organic acid, amino acid, acyl carnitine, and assay predominantly used to diagnose inborn error of metabolism. So what is this as of now? What is the status of NBS in India? So universal implementation of newborn screening is a challenge in India till now, but the increase of awareness and program over the past decade has led to more babies being screened every year. In India, this newborn screening is first started by Dr. Lal Path Lab. He started this program, and slowly it is one by one other laboratories are also starting. So now at least our little bit awareness is there, at least with the educated people, and we are getting this screened. But as per me, it should go universal. Government should apply that all babies born even in primary health center, government hospitals and all, they should also get screened. Goa state has already started this program as their universal implemented. They have implemented for all baby born in Goa. It's getting this NBS done. So I appreciate Goa government. We should also try our level best that our government also should make this universal program for all the babies. So let us, if time permits, I will go through one by one amino acid, urea, or I'll go fast little bit. Okay. So these are the amino acid disorders which can be detected by newborn screening: phenylketonuria, citrullinemia, maple syrup urine disease, homocystinuria, arginemia, tyrosinemia. So this is phenylketonuria is due to phenylalanine hydroxylase enzyme deficiency. That is not there. Phenylalanine will not convert into tyrosine, and phenylalanine will accumulate in toxic level in the baby body, and it will cause. These are the signs. You can see that irritability, seizures, Moji-like body odors, all those things. Treatment. What is the treatment? Treatment require dietary monitoring and restricted phenylalanine rich diet, that protein diet. And baby can aram se survive. If we will not diagnose this in newborn time, it will go into mental retardation and other complication. Before any complication come, it can even do brain damage also. So it's better to start treatment. And I have seen many babies who has born with this phenylketonuria has survived, and they are leading a normal life by only by diet restriction, no treatment at all. Next slide is for citrullimia. This is uric acid disorder. This is actually a critical thing, and many cases comes in the hospital. Newborn baby will have lethargy, poor feeding. They can having seizures or some breathing problem, all those things. And then all this pediatrician will send us serum ammonia level or that ammonia level in the blood. They will send us plasma ammonia level, and ammonia level is high, it means there is urea cycle disorder and something they will find out. Meanwhile, we will also give report of diet blood spot, and it will come positive. So these signs symptoms are really correlating. Seizures, coma, vomiting, signs of liver disease, lethargy, they will not have food, very difficult. They will be in NICU most of the time. And acute encephalopathy can also occur within hours or days after birth. If this is not detected, this is not getting treated. Fatty acid oxidation also can be find out by this newborn screening. These are fatty acid oxidation disorders. I'm going a little fast as time limit is there. This is also fatty acid oxidation disorder. You can see here carnitine cycle is transporter effect is there. So it will accumulate in body. This is also a life-threatening disorder. Signs of metabolic crisis is irritability. Baby will be irritable, lethargy, hypotonia, vomiting, cardiac decomposition, liver dysfunction, hypoglycemia will be there. So in this all case, we should tell that your baby should be feed every 2 hourly. These are organic acid disorders which can be diagnosed by the newborn screening. These are hormonal disorders like endocrine disorder of adrenal gland. This is congenital adrenal hyperplasia. You can see due to defect of 17 hydroxyprogesterone. So if cutoff is 20, more than 20, it means it is baby is having this deficiency. In that case, we will confirm this by serum 17 hydroxyprogesterone. It can happen in false negative, in case of false positive, in case of premature or low birth weight babies. So we have to see that also. This slide is showing about congenital hypothyroidism. This is again and a hormone disorder in which thyroid level will be more than, my cutoff of this is 10 micro international unit per liter. If more than 10, it means baby is having this thing. We will do it 2 times. If both the times it's coming high, we will inform the doctor. They will send further serum sample for this confirmatory test and other signs symptoms. They will see. They will treat the patient. Another one life-threatening disease is cystic fibrosis. This also we can find out. My reporting cutoff is 70 microgram per liter, and this is due to defect in DNA analysis, gene mutation, and all. So this can be confirmed by DNA analysis, and this can be treated. This slide is showing about galactosemia, due to deficiency of GL enzymes, and reporting cutoff is 10 mg per dl. Less than that is positive, and this is a confirmatory testing. We can do it by galactose 1-phosphate uridyl transferase enzyme activity in the serum. So signs and symptoms. One thing is lethargy, poor feeding, vomiting will be there. Apart from that, they will send it for this newborn. We can find out, okay, this is the thing, it's coming positive. So they will go for further confirmatory and they will treat the patient accordingly. This is another one case of biotinase deficiency due to deficiency of biotinase enzymes. Same are the signs and symptoms. In this, hearing loss also is there, breathing problem also is there, hyperventilation, stridor, apnea, mild hyperammonemia will be there, developmental delays if you untreated, baby is untreated. So the value of my cutoff range is for this is also 20, and it can happen positive in case of preterm birth or heat degradation of sample during transport. If imagine if I'm getting samples from Kerala or Maharashtra cluster of my own lab, so we have to pack it with the ice bags and all those things. The temperature should be maintained. Because of that also biotinase deficiency. So in those cases, in suspected cases, we'll ask for repeat sample. Slide is showing about hemoglobinopathies. We all know this. Sickle cell anemia is shown here, and mainly that sign and symptoms of anemia, jaundice, fatigue, and all will be there. Treatment is pain medication, prophylactic antibiotic, blood transfusion to avoid sickle cell crisis. So these are the thing. So finally coming to take home message for today class, that newborn screening is a test. It is just a screening test, not a confirmatory, but it helps a lot to our society. Our infant mortality rate can be reduced. So all parents should be made aware and to understand, and they should be involved on this newborn screening. Be as a doctor or as a laboratory professional, as a medical field people, we should also educate our near and dear ones, and our wherever we are working, we can start this. This is a very easy and very important and crucial test. So this is one area of expertise. So please fill correct baby detail. Whoever, we have to educate our sales team or our nurses or our brother and sister that from where we are getting sample, please collect the sample properly. Please fill the correct baby detail, and so that that specimen should be satisfactory. Otherwise, unnecessary delay will happen, and correct sample always ensures correct report. So this is the take home message for today's. Thank you. With this, I will stop sharing my slide.
Thank you, ma'am, for an enlightening session on newborn screening. I want to thank the participants as well. Any of the participants have any doubt or questions can ask, ma'am.
Hi, ma'am. Do you recommend any specific company cards or something?
As of now, I will not recommend from my side that go for this, but Perkin Elmer is the best tree in this field. Nowadays, Barter's company, and as I told you, this one, this thermoscientific is also is into this field.
Okay.
Good evening, madam.
Please speak.
Madam, can you hear me?
Yes, I can hear you.
Madam, I am Dr. Veena from Kerala.
Yes, Dr. Veena, please.
Actually, I would like to start this newborn screening program in our hospital. Actually, on an average, 3 to 5 babies will be born per day in our hospital. So, will it be feasible if I start economically?
Yes, yes, it is feasible with at least like 100 birth in a per month if you get 100 samples in a
100
month.
samples in a month, madam.
Month. So
Madam,
3 to 4 samples per day is justifiable. Yes, you can start with the smaller setup. And I will not suggest this to go for directly that LCMS setup and all those things, extended one. But basic program you can start. Basic
madam,
screening.
machine model, could you please repeat the machine instrument model?
You can take my number or my number, all of you can note it down. I will WhatsApp you the machine detail and all those things.
Okay, madam.
Can you tell my number? I
Yes,
put in the
madam.
chat. I put in the chat.
Okay, madam. Okay, thank you. Thank you, madam.
There's one question by Swati. Out of all parameters, what parameters are reported urgently before repeat test confirmation?
There is nothing like that. Any special parameter, anything which is positive coming, we have to repeat it then and there. And all are urgent only if it is positive. Everything is urgent only as per me. There is nothing like any specific that we should wait for reporting. We have to tell that consultant or neonatologist that this is coming positive. Please give us repeat sample, or we are going to repeat with the same sample tomorrow in the next run. But as of now, you can start thinking of this side, the diagnosis.
Dr. Shobha wants to ask why capillary blood and not venous sample?
Venous blood is not here, as we cannot take venous blood and put for the filter paper and all. Na? So this is a dried blood spot sample, which is the gold standard as of now. This is only came up for the newborn screening, not the capillary blood. This is easy. We cannot harm the newborn. Parents will not give. And even for that analytes also, this is only standardized to do the reference range and other things. Any other question?
What is the false positive rate for G6 PD deficiency in your lab?
5%. As of now, I have calculated it is around 3 to 5%, but 5% on an average every month we'll get this G6PD false positive.
Okay. Anyone else has any questions?
Hello. Am I audible, ma'am? This is Dr. Shubha here. Hello. Am I audible?
Yes, you are audible,
yes,
Subha.
yes, ma'am. I wanted to know what is the per sample cost for this newborn screening, one. Second one is what will be the instrument cost of this Perkin-Elmer, the autoanalyzer?
The per sample test for basic parameter, it will start from 6 to 700. Like minimum, if sample load is less, we can expect around 700 CPRT. And if sample load is more, it can go till 500 also. If for 5 parameter, I am talking about that basic test what we do through that fluoroenzyme immunoassay method. That is smaller one, and
Yes,
setup may cost you 6 to 7 lakhs, including everything, including that mixture, rotator, and incubation, everything. 6 to 7 lakh is the basic setup by which we can start this test.
Okay. Because we are in a government setup, so if we have to start this particular newborn screening, at least the basic setup, because here in our site, a lot of cases are coming up, and not many centers are doing this newborn screening. So if you have to set up a basic laboratory of newborn screening, then 6 to 7 lakhs will be sufficient.
Yeah,
that's what I
yes,
just wanted to know.
no, for this Perkin-Elmer is little costier. I am giving you the rate about Trivitron is now they have launched their kit and their everything. They will set up in 6 to 7 lakhs. Trivitron.
Okay. Thank you very much. Thank you for this excellent information and very good webinar. Thank you very much, ma'am, for sharing your expertise.
If no more questions, then we can end the session. Thank you, ma'am. Thank you, everyone, for attending.
Thank you so much.